There we go. Okay. Good afternoon, everyone. I'm sorry we're a couple minutes late. There's some other meetings going on. Some of us had luncheon meetings, and we'll have some committee members that'll be coming in that were tied up with other meetings as well. But let me call the Health Subcommittee Appropriation meeting to order, and we'll go ahead and begin. And we are also online with this. And first, though, is our presenter. We'll hear from the Department of Community Health, Kathleen Nagel.
Good morning, Mr. Chairman, members of the committee. Thank you for the opportunity to be with you again today. Again, Kathleen Nagel, Commissioner, Department of Community Health. With me this morning, or this afternoon, excuse me, is Rich Kim, our budget director, and Brandy Sylvan, our director of government affairs, is running our slides for us over there. So appreciate the opportunity to share some opening comments, I think, with you and the rest of the members of the Appropriation Committee last week, where I really talked about some of the initiatives of the department. Our kind of renewed focus on quality, accountability, and transparency. And I want to take just a moment with you and expand on a couple of those things that we're working on before I kind of walk you through our budget. So one of the first things, since I got to the department in July, we really started looking at not only what's happening in the healthcare side and healthcare policy and our initiatives, but also internally in our performance management and how we're running and operating as an organization. So we've spent some time on that. We continue to do that work. We updated our strategic plan that we submitted to OPB in September to include a new strategic planning goal of really implementing an enterprise-wide dashboard of key performance indicators for us, not necessarily for the healthcare outcomes of the state, which remain part of our mission and our overall goal, but how we're performing in support of those. So we'll spend the rest of this year really defining what those are and defining what good looks like for the Department of Community Health. I talked about, we know that our speed to get provider payments out the door is critical. Our responsiveness to our members, our ability to execute contracts in a timely and effective manner, excuse me. So we've been spending some time working on those and defining what some of those indicators look like. And as we further develop those and figure out what our baseline and metrics look like and how far we need to come to meet those goals, we'll continue to keep you informed on that. I talked a little bit previously about contracts, management administration, and that's something that we're going to spend a fair amount of time, I'm sure, talking about with you and the rest of this session in spring, is our ability to craft solid contracts with our providers. So much of what we do is through third parties, other third-party administrators, vendors, other providers, that we know it's prudent on us to develop strong contracts with strong language and service level agreement language, and even from time to time when we need to consider damages, and then manage to those, hold our vendors as well as ourselves accountable for what those performance standards are. And so I think you'll start to see some more of that from us, and be happy to talk to you a little bit more about that. And then thirdly, one of the things that we mentioned, and we'll talk a little bit in terms of quality, is this concept of incentive payments or value-based purchasing that we'll start to kind of weave and embed into more and more of the work that we do as we pay vendors rates, offering either incentives or value-based purchasing, potentially on from time to time a withhold that's only achievable when meeting certain quality metrics. You'll see and be happy to talk to you. We dipped our toe in that last year in the FY22 budget. We were funded for some additional skilled nursing facility quality performance improvement funds, that program has been designed and is pending with CMS. Essentially, skilled nursing facilities will become eligible for additional incentive payments by showing not just quality, but improvement in their quality scores. And so as we take that concept and look to other programs where we can kind of embed that same kind of work to drive quality in all of our programs, we'll do that. So we'll continue to keep you updated on that, and then share updates as they're available. In terms of our amended 22 budget, you've got a presentation from me. I'm really just going to walk you through the tracking sheet that you have, and we start on page 21. Let Brandy get caught up with our slides. The first program is Departmental Administration. There's a total of $2.9 million is the statewide change, which we've talked so much about. And we continue to be grateful for the support for a $5,000 pay increase, which our understanding will go into effect this spring. And then we'll talk about that again in FY23. $3.4 million for Medicaid Management Information System. This is our essentially our claims payment system on our fee for service side. A portion of that contract is based on a per member cost. So as our enrollment in Medicaid has been high throughout the public health emergency and increased, our contract costs related to that system also increases. $290,000 waiver advisory services. The Department of Community Health has partnered with the Office of Health Strategy and Coordination and the Office of the Commissioner in Insurance in support of the governor's 1332 Georgia Access Waiver. And part of that included some advisory services from outside folks that we were able to fund and continue to fund in terms of project management for that. So that's a replacement of those funds in our budget. 17.1.4 is $6.735 million. Increased funds to replace the Medicaid Management Information System, which goes back up to that earlier item, with the Medicaid Enterprise System Transformation. A couple of years ago, I think around 2016, Centers for Medicare and Medicaid Services issued new guidance to states on how these systems have to work, essentially requiring that whatever system the states had, we needed to reprocure, redevelop, and redesign in a modular manner. So what we do to enrolled providers exists in one module that we procure separately. How we process claims will sit in a provider, in a separate model. How we do electronic visit and verification, all these different modules. This $6.7 million will fund the system integrator that will sit on top of that, as well as those first two modules. We'll continue this implementation and development phase for the next couple of years until we anticipate going live with all modules of that system fully in about 2025, at which point that system from 17.1.2, the older system we would bring down and then either direct those costs or expenditures to cover the cost of this new system, with the intent of hopefully saving a little bit of money in the process. So happy to answer questions on that. 17.1.5 is increased funds for the all payer claims database, $2.8 million. Those funds are appropriated to the Department of Community Health. We share those via MOU with the Office of Health Strategy and Coordination at OPB, who's actually managing and administering, developing that system. And so we'll send those funds that way. And then lastly, in Department Admin, $424,000 for the Enterprise Analytics Solution for Everyone system. That is a component of this new overall technology system. That's all of our data warehouse reporting and analytics functions. Currently, we have data that resides with multiple vendors and multiple different systems. And if you were to call and ask us for some level of report, there are many times where we would have to call our vendor and say, we need to pull a query of this data. This will actually bring it all in-house. This $424,000 will actually support new positions so that we bring those analytics resources in-house and can be a little bit more timely and responsive to those types of requests. The Georgia Board of Dentistry, Georgia State Board of Pharmacy both have statewide changes for the $5,000 pay increase, $24,000 and $48,000 respectively. 17.4.1, healthcare access and improvement, just the statewide change for $30,000. 17.5.1, the same statewide change for the pay increase for the Healthcare Facility Regulation Division, $2.4 million. 17.6.1, it's $2.7 million to true up funds in the Indigent Care Trust Fund. This is so that we can use these funds as a state match for our private deemed and non-deemed hospitals to draw down additional DISH dollars on their behalf. At 17.7.1, moving into Medicaid Aged, Blind, and Disabled program. Overall, this program shows a net reduction of $265 million. 36.6 million of that is just based on projected need. We talked a little bit about some of the reasons we saw those trends in reduction over the last couple of years. 41.5 million reduction based on the extension of the enhanced FMAP during the public health emergency. So that public health emergency at the federal level has been extended, we know, now until the end of the year, actually. But at the time this was written through, this FMAP would have lasted through this third quarter, the end of March. And so this, the higher the federal cost share, the lower amount of state funds we need to match that. So this is pulling those funds back. Additional savings of 179 million based on need, and this program is being reflected as a transfer into the state health benefit program as a one-time infusion. A reduction of $14.8 million is the Part D clawback. Again, Part D clawback with the enhanced federal cost share reduces the state share required to support that line item. $6.5 million increased funds for the hold harmless provision of the Medicare Part B premiums. This is where we pay for some of those premiums for our dual eligibles. Provide funds for Medicaid reimbursement of clinical trials for $1 million. I made some comments about this in our joint hearing. CMS issued new guidance in December that effective on January 1, excuse me, the department needed to start, all state agencies and Medicaid agencies were required to begin covering routine patient costs associated with participation in a clinical trial. And so this is the amount that we've estimated will, the state share of that will be for the remainder of this fiscal year. 17.7 and 17.7.8 are true up of nursing home provider fees and the hospital provider fee, just to true up those fund sources. Next program is Medicaid Low Income. 17.8.1 has increased funds for growth of Medicaid based on need, $279 million. Again, back to that public health emergency. The maintenance of effort required in order to be eligible for these increased FMAP dollars is that we cannot disenroll or redetermine eligibility for any Medicaid member that was on or joined Medicaid eligibility since the start of the federal declaration. So the longer that goes, the higher our expenses will be in some of these programs. But similarly, that 17.8.2, the longer it goes, as we've discussed, the higher that FMAP share the federal matching is, so it reduces our reliance on state funds to meet that. 17.8.3 is a fairly small item, but sometimes it is the small things that make a difference. And this is for the Medicaid reimbursement of donor milk. We met with the Georgia chapter of the American Academy of Pediatrics pretty early on in the summer about the need for Medicaid to cover donor breast milk for very low birth weight newborns, and that it has been shown to significantly, decrease their length of NICU stays and to avoid future long-term costs associated with healthcare costs that we can avoid. And so this will be the state share that will fund that for the rest of this fiscal year. And then you'll see that carried into the FY23 budget as well. Provide funds for the Medicaid reimbursement of clinical trials, $3,580. That's the portion in this part of the budget for this program, And then 17.8.5, 4.6 million true up of hospital provider fee funds. In Peach Care, 17.9.1, $20 million increase based on projected need. And then a similar $28.6 million reduction based on the enhanced FMAP that will continue through that third quarter. Excuse me. And then if you look at it at total across our programs, some of those Medicaid changes we've summarized on that slide for you that are fairly standard that you'll see from time to time. At 17.10.1 in the state health benefit plan, it's that same 179.9 million that we saw as savings and the ABD program being reflected as that one-time transfer into the state health benefit plan for this year only. And that's the only change in the state health benefit program. In total, an additional $3.3 million, or excuse me, $3.4 million in amended, and the reflection of the total program budget across the agency of $18.4 million. We'll see a lot of those items again in FY23, but happy to talk through any of those in further detail or answer any questions that you might have.
Okay, thank you. Excuse me, do we have some questions for the commissioner? Okay, let's see. Commissioner Petrie.
Thank you, Chairman. And thank you, Commissioner, and congratulations, Commissioner. I've had a great relationship with all of our previous commissioners of this department and look forward to working with you.
Thank you.
I have, as it relates to the 2022 budget, I do have some questions that really relate to some things that we did last year, and have several. Mr. Chairman, if you don't mind, I'm going to begin with the 10% increases that this legislature provided to home and community-based service providers last session have been embroiled in delays related to CMS primarily. My understanding is to date, they still have not, we're 7 months since they were effective, July 1. They are to be retroactive, but they still largely have not been received by providers across the state. So if y'all could help us maybe. I know we'll be seeing you again here. If you could just help educate us on where we are and kind of precisely what the holdup is, because obviously during the pandemic, we've got people that need services all over the state that are going unserved, and they're largely going unserved because of workforce issues. And so the reason for those funds was like an immediate need to find workforce. And, 7 months later, a year later from when we, passed them, it really becomes frustrating, I think, to providers. So I'm hearing from a lot of those folks, and we have a conference with some of those folks coming up as well. And we want to make sure that we can accurately answer any questions they might have.
Sure.
So that's my first question.
We'd be happy to chat with you offline, get you some more details, but I think all of those rate increases, except for one, have been submitted to CMS pending their approval. We've had several back and forth conversations with them on what approval looks like in their eyes. I think our most recent conversations, and I'll go back and double check this and we can follow up with you, but there is, they've had some questions on the requirement of us to actually submit some actuarial rate studies in order to support those before they just sign off on them. So we're working through that process now. And they've had a couple other questions, but we'll continue to push them a little bit, and then happy to chat with you offline as we get some further updates, but certainly understand your point.
Yeah, and a rate study is a great idea. And it was one of the recommendations I had to the department to include in some of the pandemic related funding we got from the feds. And I'm glad we're going to do that. But in this instance, we had a situation where the legislature appropriated these funds July 1, passed, and they still haven't been received. And if you can just help us to understand
Sure.
what the holdup is and how we can accurately tell providers when to expect these funds, that would be helpful. Mr. Chairman, if I could ask another question, I've had several other members, and in particular, Representative Houston asked me to address an issue today regarding non-emergency Medicaid transport. So historically, and as someone who knows this industry well and does long-term care services, so historically we've had a real challenge with the quality of non-emergency transport services in this state. I think it's apparently increasingly worse lately, and we understand we've all have workforce challenges today. But I think there's a desire for us to understand kind of how the process works. Currently, we know we have brokers that work. At one time, we had, I think, 3 different brokers serving different geographic regions. I don't know if we have one broker now or not. I'm familiar with Logisticare, but I think there's a desire by several members to understand better kind of how the process is or isn't working, because we continue to have, one of our issues as it relates to this committee and to my committee with access to care. If physicians don't want to see Medicaid patients because half the time they don't show up, and we've all heard, every one of us, I'm sure here has heard physicians say this, that's a real issue. And it's one of the reasons that a lot of times our docs don't want to serve Medicaid clients. And so that issue, if you could help us to understand better where we are with the non-emergency transport service today, because if there's things that we need to do to try to make it better, we'd certainly like to do that.
I'm familiar with that issue in Berrien County. I think I got a briefing on that this week, and hopefully we're addressing that specific one, and happy to follow up with you offline about the specifics of that. But more broadly, I think we would agree with you. I think one of the things that we found when we got to the department, there were a number of contracts and agreements in place that had not been revisited for several years. So the NEMT contract is for brokers that then have providers in their geographic regions that they're then responsible for, essentially subcontracting out those rideshare services. We have gone to, we're in the middle of a re-procurement for those services. We expect, we're nearing the end of it. I think we'll have award announcements probably in the next few weeks, if not sometime this spring. For us, that's a real opportunity to make sure, again, to our contract management oversight, that we get it right, that there has been some quality issues, and those are some things we're looking at. I will say that in terms of contract management, that's one of the areas that our team has pursued pretty aggressively on liquidated damages when those vendors are not meeting their service level agreement. I think clients are generally give about 3 days notice. with a guarantee of being picked up and transported to their medical appointment within about a 1 hour window. When that doesn't happen the way that it should, those vendors are subjected to liquidated damages, which the department has been increasingly aggressive at going after. What we did find when we got to the department that at some point over the past few years, a cap was put on the percentage of liquidated damages that could be assigned to those. The economics of that as a provider may be different than what I would intend. And so we're removing that cap in this next round of contracts. So that we will be able to go after folks that aren't meeting the level of quality or standards that we would expect for our clients. So happy to follow up with you more detail and keep you posted as that progresses.
Thank you, Commissioner. Thank you, Chairman.
Thank you. Representative Hughley has a question.
Thank you, Mr. Chairman, Madam Commissioner. Thank you for being here. I want to talk about providers and finding providers for pediatric dentistry. I've been asked about maybe taking a look at increasing the payments for select dental codes or doing something so that we can have dental surgeons participate in that program. What say you about that?
I don't have any specific thoughts today, but we'd be happy to have a conversation, look at any of those things or do any work with you on what the numbers might look like. If you have any ideas you want to talk about.
Thank you.
Any other questions from the committee? Commissioner, you must have done a good job. Thank you.
Mr.
We
Chairman.
appreciate that, and we appreciate the responsiveness from your department when we have issues that we need to get the answer to. Thank you very much.
Thank you very much. Thank you.
Next on our agenda, this will be a virtual presentation from Dr. Kathleen Timmy, the Commissioner of the Department of Public Health.
Yeah. Thank you, Mr. Chairman. And I hope I'm as efficient as Commissioner Noggle. I have two budget items I want to present. Before I do, on the first slide, I just want to remind everybody of the unique structure of public health, because this really will help better understand the important significance of the budget items that we're going to present today. The Department of Public Health has a structure like no other state agency. We have a state office and then 18 public health districts run by district health directors who report directly to me. So they're state offices, but those public health directors serve as the CEOs of the county boards of health. And there are 159 independent county boards of health under the health directors. But the county boards of health serve as our boots on the ground and are the ones delivering the services. And we must work together as a team so that the state office, together with the public health districts and the county boards of health overseen by the public health district directors, are the public health powerhouses that have been responding to the pandemic and reflect the work being done on issues as diverse as maternal mortality to tobacco use. So this is really an unusual structure, and I think reinforces the fact that even though the boards of health are separate from the state office, they are a part of us, an integral part of us, and we must work together as a team. So the next slide is a very important budget recommendation, and I really want to thank the governor for this recommendation. And this is the recommendation for a $5,000 pay increase for all full-time benefit eligible state employees to address the agency recruitment and retention needs. But I think that this slide really demonstrates even more effectively what the impact of this budget increase will be, because every single one of our programs is going to receive funding to increase the salaries of our staff, including the key personnel who were critical part of our pandemic work throughout the last 2 years. I think it's no secret that our salaries within public health are not even close to what is needed to recruit and retain good staff. And we are in a particularly difficult situation here in being in Georgia, not only because we lose really good staff, epidemiology staff, immunization, nursing staff, environmental health staff to other states, to other agencies, but to private sector. For example, epidemiologists have gone to private sector companies and even to school districts and have made significant increases in their salaries. Environmental health inspectors have gone to the private sector, as well as FDA and CDC, and so that Chick-fil-A can pay significantly more than we can. So I think that this, what seems to be perhaps a relatively modest increase in salary, is a dramatic increase for many of these staff. A starting level environmental health inspector with this will have a salary increase of 15% with this $5,000 increase, which is really going to help us to keep good staff on board. An epidemiologist has no career ladder to move up, and with this $5,000, we can help retain staff with what will be significantly about 11% increase to this EP2 position, this promoted position, which really barely is nowhere near market midpoint. And so I hope that this will be, I think, really beneficial for us as we begin to recruit and retain our good staff, whether they be nurses, that all of us are having a hard time recruiting in the health sector, but also these other specialties staff that have been the foundation of our pandemic response. And I really am very, very grateful to the governor for recognizing this need and helping us meet those goals of keeping our staff on board. The second and only last budget item I'd like to present is the increase in funds to address the state fund shortfalls for the AIDS Drug Assistance Program, also known as ADAP, as well as the other Ryan White Act Title II healthcare awards. This 9.9 million is significant because it will allow us to meet our state required match, but it will also allow us to meet the needs of the growing number of clients served by this program, and will avoid us having to do a wait list, which is where we were last year. I think many of you are probably thinking, why do we need this again? We had the kind of a budget plug last year that was allowed us to avoid a wait list. But I'd like to kind of talk you through why we need this now. And also that with this increase in funds, we will put the program on a path to sustainability to be able to continue to serve the maximum number of people in the most efficient and effective way. And what is in fact a critically important program for our state. Next. If you look at this map, what you may not realize is that the South reports the highest rates of HIV infection in the country. When HIV was first identified in the 80s, it was largely confined to the coast, New York, San Francisco, Los Angeles. And only now, much later, do you see these high rates in the South, in all states in the South, as well as the District of Columbia. But the challenge is that Georgia reports the highest rates of HIV in the entire country, and particularly Atlanta metro area. There are probably a number of factors that contribute to that, both in the greater metro area as well as the rural areas. It includes everything from lack of access to care, poverty, certainly stigma associated with the disease, but also just many other issues of access to care. And we also recognize that with the availability of these funds, we can address these treatment needs throughout the state, as well as in Metro Atlanta. We are seeing in the next slide that the demand for these services is increasing. And there's a reason for that. Part of that is that, yes, indeed, rates are increasing, but also the work we are doing to identify individuals in need has really been very much and very aggressively increased. We were the lucky recipients, I think the fortunate recipients of an End the HIV Epidemic grant award from the Centers for Disease Control and Prevention. This was an initiative under the Trump administration that got a great deal of recognition, and the Metro Atlanta area was particularly focused on with this award to do more outreach, to identify individuals at risk, to test, and to ensure that they were transferred into care. And that work was also allowed to continue throughout the state, so that we have basically increased and ramped up that identification of individuals in need. And so that has, coupled with that growth, has really increased the demand for the ADAP program, which is the payer of last resort. I want to again reinforce that we are not the first place people go for care. We are the last payer, but an essential payer, because the importance of treatment cannot be understated. When individuals are on treatment, they are no longer able to transmit the virus. And even as we were doing outreach to identify individuals, to test, to identify high risk but uninfected individuals and ensure that they remain uninfected, if we identify people at risk who are infected, we can quickly ensure that they have a linkage to care, and they no longer then, if they are sustained on this medication, will no longer be able to transmit HIV. What we have said is the treatment is prevention, because the virus virtually disappears. And that is so important to sustain these programs, because you don't want to start people on medication and then have them drop off medication because we don't have the funding capacity to continue treatment through ADAP or the Health Insurance Continuation Program, which is part of this Ryan White program, which provides an extension of insurance coverage to those who may have lost insurance, that can continue to receive the HIV services, as well as the benefit of other healthcare services. And we have actually, again, since last year when we first met and talked about this, made a very deliberate effort to restructure our program to ensure not only sustainability of the program, but also more efficiency within the state office and how it's carried out in the districts, to try to encourage more individuals to enter the HICP program, which provides a broader range of services. But that is one reason why that graph shows not only that increase, but even higher. I would just like to close with just a few key takeaways. These programs in the Ryan White service programs, ADAP, the AIDS Drug Assistance Program, and HICP, the Insurance Continuation Program, are essential to ending the HIV epidemic here in Georgia, and really coupled together with the prevention efforts that we are doing with our federal CDC funds, are key to our being able to end the explosive growth of HIV, not just in Metro Atlanta, but in rural areas of Georgia. ADAP and HICP have experienced sustained enrollment and growth for all those issues that we've talked about, including just our capacity to better identify individuals in need. And because of that, at our current funding levels, we are unable to continue to give everybody the treatment that they need to have to ensure that they not only have the care to help them to lead a healthy, long life, but also to reduce and stop transmission to others. The governor is recommending an additional state funds of $9.9 million, both in this budget year and then in FY 2023. And that will allow us to meet utilization growth demands. It'll help us stabilize the program even as we restructure and streamline, and will fully fund for the first time the state match that we are required to have by the federal funders, and it will help us avoid a waiting list. A waiting list would be devastating to us in the state. We would be the only state in the country with a waiting list if that happened. And all these things, this 9.9 million will actually be able and allow us to address all of these issues. So there's a lot of information, but I really appreciate the opportunity, Mr. Chairman, to go over these once again. And I'm not going to launch into COVID unless you want me to at some point later in the hearing, because I know I spent half my time in the joint budget hearing talking about it, but I'd love to answer any of your questions on either the HIV or the salary increases, which are both most welcomed and appreciated. With many thanks to the governor and his team.
Thank you, Dr. Timmy. We do have some questions for you. Is that Representative Hughley? Ms. Buckner. Okay, go ahead. Thank you.
Thank you, Commissioner Timmy. I have a question about the staff pay for public health workers. Do you have the capability within your agency to do like a pay scale evaluation to, I know the raise will help, but I am certain that y'all are underpaid compared to the healthcare market. But do you have that capability within your department to assess how far off you are from the pay that you need in order to recruit and retain workers?
Yes, ma'am, we do, and have looked into that. For example, the salary midpoint for some EPI positions is around 16,000 less than the market median. So it's no wonder that we're losing EPIs to school districts as well as to CDC. Yes, we have actually done that.
Okay, thank you. That would be good information to have.
Do we have other questions? Okay. Timmy, thank you very much for your presentation. I want to personally thank you for the work that you and your team are doing, and especially your folks who are out there on the front lines every day. They've really been under the gun for the last couple of years trying to help us to right this pandemic that's out there. And we just want to say thank you. And I feel like that it's the intention of the governor by the budget that he has presented to try to eliminate the problem we've had with ADAP and some of these other issues like that. So anything else you need to share with us?
No, thank you, sir. Your thanks is much appreciated. I think just hearing you say thank you to the team throughout the state really means a lot to them. So we thank you so much.
Great. Thank you. Okay. Our next presenter, this will be a virtual presentation also, Freeman Montague from Interim Executive Director of the Georgia Board of Physicians Workforce.
Yes, good morning, Mr. Chairman. Can you see the PowerPoint presentation?
Yes, we can see that there. It's
Okay.
Georgia Board
Great.
of Workforce, excuse me.
Okay, yes, thank you. So the recommendation is just one for the Workforce Board. It is 17.11.1 to increase the funds for a $5,000 pay increase for full-time benefit eligible state employees. And that is for $24,234. And just to show in the summary, again, that is the only change for our FY22 budget. The amounts for what we have currently remain the same. So it would, excuse me, just be that one increase of $24,234 to address the salary increase, and it would bring the amount up to $91,413,845. And that is the only item, Mr. Chairman.
Okay, any questions or comments from the committee? Seeing none, good job with your presentation there. Thank you.
Thank you.
We'll move right along now to an in-person presentation, the Georgia Trauma Commission, Liz Atkins, Executive Director.
Good afternoon. Gabby's going to pull up our sheet, and can you all hear me okay? Okay, great. All right, so I think you all have the sheet in front of you, correct? Yes, sir, thank you. Thank you for having us today. As you know, our amended allocation is typically a true up from the fireworks excise funds as well as the super speeder fund. So I'll focus on that today. And I just wanted to start by saying the allocation that we received last year really helped us kick off our risk adjusted benchmarking outcomes. As the DCH commissioner spoke about, unless you have the ability to get that data in-house, you can't really tell what's really happening. And this will give us a sight line into the performance of our trauma centers and our system that we have really not had before. So as you know, we've really gotten tight on our accountability, and we don't just hand out money anymore. We actually have pay for performance metrics with the system. So this will help us really propel that forward. So with this additional funding this year, you can see I've kind of sorted it out by initiative for you. And we call the top initiatives around system quality and accountability. And between last year and the year before has been our biggest focus on rural South Georgia, because we know we have problems getting patients out of those rural areas and into the tertiary care centers. And COVID really complicated that for us because the tertiary care resources were already depleted. So we were hearing from a lot of our stakeholders across the state that they were having trouble moving patients around. So we have a really tight-knit group, luckily, with only having 34 centers, even as basic as just a text message between each other. Hey, how can we, move patients? Where can we, where can we find room? Well, what we want to do is have the American College of Surgeons, and I apologize, I'm seeing now that we have some abbreviations on our sheet that I know that the committee is certainly not familiar with. We'll try to avoid that in the future. But the American College of Surgeons is that national committee that really sets the standards for what trauma systems and trauma centers should do in terms of best practice and excellence. So we want to have them come in. They do system consults. And at the outset, when the commission started in 2007, we had a system consult. We want to have that again, but we're partnering with them now to do a rural focus, because oftentimes what happens when they come in to look at the system as a whole, they just can't help but focus on some of those urban areas where the problems might be a little bit more magnified. But we want to recruit a panel of experts just to come in and sort of help us figure out are there some best practices that we can model for some of our more rural areas. And then the second thing on the list is that through the American College of Surgeons, they offer an ability for a center to participate in national benchmarking. Our level 1 and 2 trauma centers, which again are mostly the urban centers, have been doing that for a long time. But we want to ensure that the level 3 centers, which largely do serve a less urban population, are able to continue to participate in that. And then we can pull them into that advanced database, data analytics set that we're trying to get pulled forward. So again, more sightline into what their performance looks like. And then the other service that the national entity offers is that trauma center level expert analysis, where a panel of experts again comes into your facility. They review you similar to like a state designation visit and kind of offer you some sage advice about where you can improve. So we want to do that for the level 3 and the level 4 trauma centers, just to give them some additional help. A lot of times you can be working in a trauma center for a long time and have good relationship with your C-suite, but it's not until that external person comes into your building and says, hey, you really should do that you really get the focus and attention of the top level executives in your hospital to move forward with some of the initiatives you need. And then along the line of the data and analytics, one of the things that we've realized with some of our rural centers is that they don't have the IT infrastructure to support a database that's kind of warehoused on their hard drive or somewhere within their system. So if we can help support their web host subscription so they don't have to deal with any of the updates that come along, we're going to more reliably get their data. Right now, it's a little sparse. Sometimes it depends on if they have the workforce in order to actually abstract and put the data in. We want to make it a little bit more automated for them. Again, if we don't have the data, we can't really get a sight line into what's happening. And then perhaps the biggest portion, excuse me, of our funding is to increase what we call the readiness funding, which you see a large portion of our base budget goes. And, you know, we've done a lot of analysis on readiness costs at the level 1 and level 2 center level, which is our funding accounts for about 7 cents on the dollar what it actually costs for a trauma center to be ready. What's very exciting is right now I'm sitting on the data that we just collected for the level 3 and level 4 centers. First time ever, we now have data on what it costs to be a level 3 or level 4 center. Our hope is that once we can do a deep dive on that, maybe we can figure out what it actually costs to become a center at that level, because we're more likely to increase access by increasing the level 3 and level 4 centers. And then you see the Department of Public Health Office of EMS and Trauma. By code, we can give up to 3% of our budget. So we try to maintain their allocation consistent. So that would be a true up to what they got last year, just to keep their allocation the same. And then the 911 ambulance equipment grants. Primarily, this is done through equipment grants, but we put pre-hospital provider training. As you mentioned, with a lot of the workforce challenges and certainly with EMS, one of the ways to recruit them is really invest in their education, making sure that they're getting the training that they need and they desire, and particularly to be mobile and hopefully retain them in the workforce and not have them go look for opportunities somewhere else. And then you see our total is a little bit over what the allocation is, but the commission votes on this really early. We really work on this all year. So ultimately what we do is pretty much keep the initiatives the same, but probably just adjust the amounts a little bit. Usually it's out of the big chunks with the increased readiness for the trauma centers and for the EMS equipment grants. So with that, I'm happy to take any questions.
Okay, thank you very much. Do we have some questions or comments from the committee? Liz, thank you.
Sure, thank you.
Appreciate you being here today.
Thanks so much for the opportunity to present to y'all.
Yeah. And I want to thank the committee for showing up today, and those in the audience who are interested. We appreciate your attendance as well. This budget that we're looking at today is pretty much straightforward, and there's just not a lot in there to look at it at this moment. It's pretty self-explanatory and straightforward, but we'll be looking at this as we go along, and then we'll be in touch when we get ready to have our next meeting and move along. Any other comments or questions before we adjourn? If not, thank you all for your attendance. We adjourn.